Good evening, everyone. How are you? Everybody good? So nice to see everyone here today. Welcome to session 3 of CPT group study. And we hope to give you the steps to solve CPC exam case scenarios. And before we go any further, I want to introduce my wonderful team, and we'll begin with Mr. Sandeep, who is coming to you live from Abu Dhabi. It's about 4 a.m. Hello, good morning, Mr. Sandeep.
Good morning, Mrs. J. Hello, coders. How are you all doing? Welcome to the third session of Study Group by AMCI. Now, since we are not having the class on Saturdays, we made sure that we are going to have an action-packed Tuesday session. So hope you will enjoy. Happy coding.
Thank you so much, Mr. Sandeep. Was that correct? It's 4 a.m.?
Yes, Mrs. J. It's 4 a.m.
Awesome. I believe he's in the United Arab Emirates, if that's correct also.
Yes, Mrs. J.
Awesome. Okay, I almost skipped over Miss Eva. How are you, Miss Eva, in sunny Florida? How are you?
Hi, hello, coders. Hi, Miss J, Mr. Sandeep, all interns. I'm so happy and excited to be here. I'm doing super hot here in Florida, but it's been a sunny day, and hopefully you guys can enjoy it as much as I am. And I hope to see you in the chat and get coding.
That's right, get coding. And last but certainly not least, me, Mrs. J. I'm in the city. Hello. Someone's on mute. Not on mute, excuse me. Let's see. Who might that be? Okay, everybody, every team, please put yourselves on mute. All right, it is me. I'm coming to you from the cool and breezy southwestern Pennsylvania. It is gorgeous here. And our amazing interns are in the building, and we're going to feature them tonight. I'm really, really excited. All right, we're going to start with Miss Carla. How are you?
Hi everyone. Hi coders. Hi Miss Anu, Mr. Sandeep, Mrs. J, Miss Courtney, Miss Dolly, Miss Eva, Miss Vivian. Glad to be here. Welcome to session 3 of the study group. We really appreciate you all being here. So let's get it. Let's code, coders.
Let's do it. You know what? We just may coin that. Let's code. Yeah. All right, Miss Courtney, how are you?
Hello, coders, and welcome back to another study group. We've got a lot of awesome scenarios tonight, and I think they will be super helpful for you. So we'll talk to you guys in the chat.
All righty. Next up, Miss Dolly. How are you, Miss Dolly?
I'm well, Mrs. J. Good evening, coders. I hope everyone is doing well. I'm looking forward to going over some great practice with you all tonight, and I'll see you guys in the chat, and I know you all are going to rock it.
Yes, indeed. I got a feeling they're going to rock it too, Miss Dolly. And Miss Vivian. How are you, Miss Vivian?
I'm good, Mrs. J. Welcome, coders, to this week's group study. I'm excited to be here, and I hope you're just excited to code with us. Anyway, I hope you guys have a great evening.
If that wasn't the sweetest introduction I've heard in the longest time, Ms. Vivian, so glad to have you here. And last but certainly not least, Miss Anu, how are you?
Hi, Mrs. J. I'm good. Thank you. Hi, interns, and hello, coders. Welcome you all. And I hope this evening will be very good. And I'm very glad to be here. Let's see all in the chat.
All righty. I think that's a good way to end it. And welcome, 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 all of you. Let's get started. Okay, we're going to begin with the goals of the presentation. Number one, we're going to talk about urinary system scenarios, female system scenarios, nervous system scenarios, and if we have enough time, we're going to review anesthesia. But before we begin, let's review how to solve a multiple choice case study scenario for the board exam. And the first thing that you must do is highlight your key terms. Don't forget, yellow means diagnoses, green procedures, and pink, this is inclusive. It could be bundled or included. In other words, it's not coded. Number two, document your inventory procedures and diagnoses. Then you select the primary. Number three, review all guidelines. Four, select the code that best matches your inventory list. That kind of makes sense, right? The code language should match your inventory or best match your inventory most of the time. All right, so here are some time-saving techniques, meaning you do not have to highlight the following. Number one, things observed by the physician. Number two, closures, sutures and staples, etc. And when I say closures, closures when it's not considered the treatment. Often when you have sutures that is the treatment, of course you're going to code that. Repairs, sometimes when they repair wounds, that's treatment. But if you're just closing the surgical site, that is not treatment. Okay, and this closure means closing the surgical site. Number three, hemostasis or bleed control. We're not going to code it. We're not going to code drains, not irrigation of that surgical site. We are not going to code installation and removal of clamps and trocars. These devices often keep the surgical site open so that the surgeon can carry out the procedure. Number seven, dressings. And finally, surgical risks. When I say risk, these are the risks that the surgeon have outlined are the potential complications of the surgery. So of course, you're not going to code that because it's not a diagnosis. All right, so now we are going to get started with the male urinary system. And I'm going to ask Mr. Sandeep to take the screen. And well, I'm going to give him the screen. And I'm going to invite Miss Courtney to the floor.
Thank you, Mrs. J. Miss Courtney, would you please read this scenario for me?
Mr. Sandeep, would you show your screen?
Yes, here it is.
All right. So first I'll read the question. What are the CPT and ICD-10 CM codes reported? A 50610 and N20.1, B 50630 N20.1, C 50945 N20.1, and D 50080 N20.1. Pre-operative diagnosis, right ureteral stones. Post-operative diagnosis, right ureteral stones. Operation, open right uretolithotomy. Intraoperative findings. The patient had marked inflammatory reaction around the proximal ureter just below the renal pelvis. Multiple stone fragments were embedded in the edematous ureteral lining. Procedure. The patient was placed on the operating room table in the supine position. General anesthesia was induced. He was then placed in a right flank up position. An incision was made off the tip of the 12th rib and dissection was carried down through skin, fat, and fascia to open the lumbodorsal fascia entering the retroperitoneal space. The peritoneum was swept anteriorly. Careful dissection was then carried down in the retroperitoneal space to first identify the vena cava and then to identify the renal vein. Once these structures were localized, the ureter was identified. Careful dissection was done to mobilize the ureter and to identify the area of the stone impaction by palpation. The ureter was then opened longitudinally and the ureteral stent was identified. The multiple embedded stone fragments were then removed from the ureteral lumen. The ureteral lumen was then irrigated copiously and no other stone fragments were identifiable. The ureterotomy was then reapproximated with interrupted sutures of 5-0 chromic. Inspection showed good hemostasis. Sponge and needle counts were correct, and closure was begun after placement of a Blake drain through separate inferior stab wound. Marcaine 0.5% with no epinephrine was used to infiltrate the intercostal nerves. The wound was then closed in layers with muscle and fascial approximation with number 1 Vicryl. The skin was closed with staples. Sterile dressings were applied. The patient returned to the recovery area in satisfactory condition. All right, coders, your time starts now.
So coders, I think that's 2.5 minutes. And from the answers which I see in the chat, I can see a split between the option A and option B mainly. So I think this is going to be a teachable moment. Thank you, Miss Courtney, for reading out that long scenario for me. Okay, in meantime, coders, if you haven't figured out the answer, you can put them in the chat. We will go ahead and solve the scenario. We are coming to the first step, that is highlighting the keywords. The post-operative diagnosis is same as the pre-operative diagnosis. It is right ureteral stones. And the procedure which is performed in this scenario is open right ureterolithotomy. You can see an inflamed reaction was there for the patient around his proximal ureter. He was placed in a supine position under general anesthesia in a right flank up position. An incision was made in the tip of the 12th rib. The dissection was carried and peritoneum was swept. Then dissection was carried down to the retroperitoneal space and the ureter was identified. The ureter was then opened and and finally multiple embedded stone fragments were removed and irrigated copiously, and finally the patient is returned to the recovery room. So the procedure inventory. Next step is having our procedure inventory and diagnosis inventory. Here we have got open right ureterolithotomy, which is the procedure performed, and the diagnosis inventory we are having right ureteral stones. And now you can see the diagram, a diagrammatic representation of human urinary system. As you know, human urinary system consists of kidney, a pair of kidney, a pair of ureters, bladder, and urethra. So the renal stones or urinary stones are one of the most common complaint or the diagnosis for which the patients comes in the urology department in hospitals. So what happens is that a stone will be formed in any part of it can be formed in any part of our urinary system. It can be in kidney, ureter, bladder, urethra, and in our scenario it is in the ureter, which is a tube that carries the urine from the kidney to the urinary bladder. So a formation of a stone in the ureter can causes a block of urine flow from kidney to bladder that can result in backflow of urine and may damage the kidney as well. So you can see the image. The stone is in the ureter, and the procedure performed by the doctor is a urethral open a ureterolithotomy. The doctor will be doing an incision and removing the ureter stone from the ureter. So that's all about the procedure performed. And these are our diagnosis options which we are having. And let's begin the process of elimination of our wrong answers. Let's look into for the option D first, 50080. That is coding for percutaneous nephrolithotomy or pilostolithotomy. So as the code language states, it's a percutaneous approach which has been performed. Cross-checking with our procedure imagery, we are having open right ureterolithotomy, and from the approach we can cancel option D. Now let's look into the next one, 50945. That is, once again, the approach is a laparoscopic surgical approach. Let's cross check. Our is open right ureterolithotomy. Once again, the approach is different and we can eliminate option C. Now the remaining two answers are option A and option B. That was the main competition was between option A and option B. And let's look what option A is coding for. It is 50610. It is coding for ureterolithotomy, upper one third of ureter, and 50630, which is coding for ureterolithotomy, lower one third of the ureter. And from that, I would pick my answer as option A, 50610, upper one third. How? This is how I got my answer. The patient had marked inflammatory reactions around the proximal ureter. You can see a proximal ureter, the inflammatory reaction was around the proximal ureter, so which constitutes upper one third of the ureter. And you can see another diagrammatic representation of how the ureter is classified. It is classified like upper third, middle third, and a lower third. So in our scenario, it was in the proximal ureter. That is, of course, that is a upper one third of the ureter, upper third part of the ureter. So that would be where the stone removal must be done, and hence we can eliminate option B, and the correct one will be option A, 50610 and 20.1. How do you feel about that, coders? Do you have any questions on this one? Was this an aha moment for those who picked option B? Okay, I think there is no other further questions on this scenario. And let's move on to the next one. Okay, for this scenario, I think Miss Eva, can you please read this scenario? It's a lengthy one. Can you please clear out this for me?
Sure thing, Mr. Sandeep. Okay, coders. What are the CPT and ICD-10 CMs code reported? A, 55866 C61, B, 55815, C61, C 55845, C61, D 55831, C61. Case 2. Operative report, preoperative diagnosis, prostate cancer, postoperative diagnosis, same. Procedure, radical retropubic prostatectomy with bilateral pelvic lymph node dissection. Statement of medical necessity. The patient is a very pleasant 58-year-old gentleman with Gleason 7 prostate cancer. He understood the risk and benefits of radical retropubic prostatectomy, including failure to cure, recurrence of cancer, need for future procedures, impotence, and incontinence. He understood this risk and he elected to proceed. Statement of operation. The patient was brought to the operating room and placed on the operating table in the supine position. After adequate general endotracheal anesthesia was accomplished, he was put in the dorsal lithotomy position and was prepped and draped in the usual sterile fashion. A 20 French Foley catheter was introduced in the patient's urethra, and the balloon was inflated with 20 millimeters of sterile water. Made a midline infraumbilical incision and dissected down to the rectus fascia. Then transected the rectus fascia between the bellies of the rectus muscle and dissected it into the retropubic space. Placed a Bookwalter retractor to aid in visualization and to protect the surrounding structures. Perform a bilateral pelvic lymph node dissection, taking care to avoid the hypogastric and obturator nerves bilaterally. The node packets were sent off the field for permanent section and frozen section. Then dissected the prostate free from its lateral sidewall and dorsal attachments superficially and placed a right angle clamp behind the dorsal venous complex and tied off the dorsal venous complex with 2 free ties of number 1 Vicryl. Sew some back bleeding sutures over the prostate and place a right angle again behind the dorsal venous complex and then transected it with a long handle blade. Carefully inspected the dorsal venous complex for any bleeding and no bleeding was noted. Then placed a right angle clamp behind the urethra and transected the anterior aspect of the urethra, exposing the Foley catheter. Grasp this with a tonsil and then cut off the Foley catheter and at the urethral meatus and pull the Foley catheter into the urethral incision that had been made. Transected the posterior urethra, freeing the prostate from its apical attachment. This allows us to apply upward retraction to the prostate and dissect it free from the rectal anterior wall. Clipped and cut the lateral pedicles to free the prostate up to the level of the bladder neck. Transected then umbiliars fascia and identified the bilateral vas deferens, which were clipped and cut accordingly. Also dissected the seminal vesicles, leaving the tips of the seminal vesicles in place in the hopes of improving his incontinence. Once this was completed, dissected the prostate from the bladder neck using electrocautery. Opened the anterior aspect of the bladder, able to identify the bilateral urethral orifices, efflux and indigo carmine that had been administered about 10 minutes earlier by the anesthesiologist. Once the prostate was sent off the field for permanent section, attention was turned to recapitulating the bladder neck. Everted the bladder mucosa with 4O monocryl and then closed the bladder neck in a tennis racket closure using 2O Vicryl. Then placed rod sound in the patient's urethra after ensuring adequate hemostasis in the pelvis and placed 5 anastomotic sutures of 2O monocryl surrounding the urethra. Place them in the corresponding location in the bladder neck after a Foley catheter, 20 French in size, had been placed through the urethra and into the bladder, and the balloon was inflated with 20 millimeters of sterile water. Cinched down these anastomotic sutures and tied them off, irrigated the Foley catheter, and ensured that there was no bladder leak. We then placed a JP drain in the patient's left lateral quadrant, taking care to avoid the epigastric vessels, stitched the drain and placed with a 2O silk, closed the fascia with a number 1 Vicryl in a running fashion, and closed the subcutaneous tissue with a 3O Vicryl. The skin was stapled closed and a sterile dressing was applied. His catheter was again irrigated with return of blue urine, no clots. The patient was extubated and taken to the recovery room in good condition. Coders, you have 2.5 minutes. Coders, time is up. Mr. Sandeep.
Thank you, Miss Eva, for reading that long scenario. So, coders, from the chat, what I can see is that you guys are nailing these operative scenarios. Can see a lot of correct answers. And let's move on and solve the scenario. Let's have our key terms, keywords. Post-operative diagnosis and pre-operative diagnosis are the same. They are prostate cancer. And the procedure performed is radical retropubic prostatectomy with a bilateral pelvic lymph node dissection. And here we are having a 58-year-old patient and the lesions for 7 prostate cancer. Radical retropubic prostatectomy is performed. There's a chances of failure to cure, recurrence of cancer, impotence, and incontinence. A patient was placed in supine position, endotracheal anesthesia was given. He was put in a dorsal lithotomy position. Foley catheter was placed into the urethra. Balloon was inflated. Infraumbilical incision and was made, and it was dissected to the rectus fascia, then transected to the rectus fascia, the base of rectus muscles, dissected into the retropubic space. Bookwalter retractor was used. Bilateral lymph node dissection was then made. We have dissected prostate. Right ankle clamp was placed and tied off the dorsal venous complex and sewed back bleeding sutures, placed right angle again and then transected it. Transected the anterior aspect of the urethra, cut off the Foley's catheter, pulled the urethral incisions and transected the posterior urethra, applied upward retraction, dissected it free from rectal anterior wall, and clipped and cut lateral pedicels, then transected deno-villus fascia and clipped and cut accordingly, dissected the seminal vesicles, dissected the prostate, and from the bladder neck using ultracautery, opened the anterior aspect of the bladder, recapitulating the bladder neck, and placed a 5 anastomotic sutures and Foley catheter 20 French in size, and balloon was inflated. So that was a lot. And answer to this scenario is option C. And let's move on and let's solve this scenario now. So what happened is, in this case, is the patient was having a prostate cancer, and the procedure which is performed is a radical prostatectomy with a lymph node dissection. So basically they have removed the prostate of the patient along with the surrounding lymph node, and this can be done in several approaches. One method is a retropubic approach, in which the incision will be made in a position lower than the pubic bone and not to the opening of the bladder. The another technique which can be used is a suprapubic approach, in which the incision will be made above the pubic bone of the pelvis through an opening in the bladder. And one another technique is perennial, which you can see the incision will be made around the perineal region and the prostate resection will be done along with the lymph nodes. So these are the approaches which are used to perform the prostatectomy, and it can be done in different stages. They will first remove the lymph nodes, as you have read in the procedure note. Then sometimes they will do the nerve sparing in order to preserve the erections, and finally the prostate will be removed and a Foley catheter will be placed. So that's the what happened. The prostate towards the final portion, the prostate was dissected from all the surrounding tissues such as urethra, bladder, etc., and that is finally removed. Okay, and let's move on to the next step, the coding portion. Let's have our procedure inventory. The procedure performed is radical retropubic prostatectomy and bilateral pelvic lymph node dissection. Diagnosis, we are having prostate cancer and a Gleason score, Gleason 7 prostate cancer. Actually, the Gleason is a score. A Gleason score is a grade that doctors use to grade the prostate cancer. So depending upon this score, they will determine the kind of treatment the patient needs, the kind of the extension of the surgical approach that is needed to treat the prostate cancer. So the principal procedure will be radical retropubic prostatectomy with pelvic lymph node dissection, and the principal diagnosis will be prostate cancer. And as I said, Gleason is a score which is given to prostate cancer. We won't be coding them separately. So coders, select the best code that matches your inventory list. That is going to be key in solving this scenario. It might look like a big scenario, but coding is much more simpler for this. And let's start solving the case. I have shown an image of how we have done a churning for this procedure. For the prostatectomy, you can see the codes range from 55810 to 55815. That is a prostatectomy which is performed using the perineal approach, one of the approach which I mentioned in the beginning of this scenario. And then we are having the code 55821, that is coding for suprapubic approach. And we are having the code series from 55840 to 55845, that is for retropubic approach. And last, we are having 55860 to 55865 for exposure of prostate to the radioactive substances. So I have all the procedures churned and ready, and I will show how a churning can come very useful in solving these scenarios. And the key tool which we are using to solve is selecting the code that best matches our inventory. So coders, let's begin the process of elimination. The first, let's look into the code 55866, which is coding for a surgical prostatectomy by a laparoscopy approach. You must have seen from the procedure note that an midline incision was made in the infra-umbilical area, and that is not a laparoscopic, that's an open approach. So we can eliminate option A straight away. Now let's look into the next one. That will be option B, 55815, which is coding for prostatectomy perennial radical with bilateral pelvic lymphadenectomy. And as you have seen how I churned this, it is a prostatectomy using the perennial approach, and cross-checking with our procedure inventory, it is not a perennial approach which was performed, it was retropubic approach. That cancel out option B. Now let's look into the next one, that is 55831, which is prostatectomy retropubic subtotal. Well, it was not a subtotal prostatectomy which performed, it was a radical prostatectomy along with the pelvic lymph node dissection. And this code also doesn't matches our inventory, doesn't completely define the procedure performed. That eliminates option C as option D as well. I was talking about the option D, sorry coders. That eliminates option D as well. And the final answer option will be 55845. That will be our correct one, which is coding for prostatectomy with bilateral lymphadenectomy, including retropubic approach. I'm sorry, prostatectomy, retropubic radical with or without nerve sparing, with bilateral pelvic lymphadenectomy, including external iliac, hypogastric, and obturator nodes. So that's a code which we were looking for, and that is our answer. Option C, 55845. So easily having the CPT book churned by at a glance, I can see the approach which is used for performing the prostatectomy, and I can eliminate a couple of options, wrong answers from directly looking to the approach itself without reading the CPT. So that's how we save time during the exam, and you must be knowing each second saved is gold during these time-based exams. So that's why we say churning is life, churning is gold. So any questions on this scenario, coders, you can put them in the chat. And we will be happy to answer it. So next comes is it is back to you, back to Mrs. J. Mrs. J.
Yes, thank you, Mr. Sandeep. All right, how are you feeling? Everybody good? Let me look in that chat. Okay, good deal. So while I'm getting myself together, I'm going to ask Miss Eva to come to the fore because we are getting ready to begin a new section, the female reproductive system. All right. Okay, Miss Eva, take it away.
Sure thing. Ready, coders? Let me read the question. What are the CPT and ICD-10-CM codes reported? A. 571.50 and 81.3. B. 571.55 and 81.3. C. 571.60 and 81.3. D. 571.70 and 81.3. Case 1. Diagnosis: Stage 3 Cystocele, Stage 2 Uterine Prolapse. Procedure: pessary feeding. Indications: a 75-year-old gravida 4, para 4 female with pelvic organ prolapse. She is back for a pessary feeding today. findings, she has a third-degree cystocele, and after examination, we've determined she actually has a third-degree uterine prolapse. Her vaginal tissues are improved but much less thin than prior appointment. Description of procedure. After her exam, I started with a number 4 ring pessary with support. This was clearly not large enough, and the cystocele was coming around it. Then went to a number 5 ring pessary with support with the same problem. I went to the number 6 pessary with support. It did not lodge behind her pubic bone very well, but it definitely reduced all of her prolapse. She mentioned earlier in the appointment that she could not void when she came in today. She had not tried reducing it. I am hopeful that the pessary may help with that. The number 6 was comfortable for her. I stood her up and put her through some maneuvers and it stayed nicely in place. Then she went walking with the pessary in place for 10 to or 15 minutes and went up and down the stairs. She was able to void more easily with it. With it. It was comfortable and she did not really notice it was in. On recheck, it still seemed like she had a little more room in the pelvis. I removed the number 6 and went up to a number 7 size. This seemed to reduce the prolapse a bit better, but was a little uncomfortable for her. We went back to the number 6 ring pessary with support. She was able to remove it and place it with instructions in our clinic today. Disposition. We have ordered the number 6 pessary with support and it will be sent to her. After she gets the pessary, she will remove it once a week and leave it out overnight. She will continue to use the Premarin vaginal cream twice a week. She will return to clinic after she has used the pessary for 2 or 3 weeks, so we can check her tissues. She is to report if she has vaginal discharge or bleeding, as she is at risk for getting ulcerations from the pessary. I answer all of her questions about her condition of pelvic organ prolapse and treatment with estrogen and pessary. She will call if she has any bleedings. Coders, you have 2.5 minutes. Your time starts now.
OMG. You all are rocking in that chat, and no way am I going to give you 2.5 minutes. You all are on fire. You didn't need it. Look at that huge scenario, a big scenario, and you were able to solve it in seconds. That's what we need to see. I see that confidence just growing. I see it. Tell me if I'm wrong. Say, no, I'm not getting confident. Or, you know what? These are AAPC scenarios. You guys are rocking. All right. So, this 75-year-old young lady was diagnosed with stage 3 cystocele and stage 2 uterine prolapse, and she's in for a pessary fitting. Pelvic organ prolapsed is her diagnosis. Pessary fitting, I made it pink because it's, bundled. I'm just duplicating. Also, it says she has third degree cystocele. That's already been established. But after examination, they've determined she actually has third-degree uterine prolapse. Number 6, ring pessary. These are all of my keywords. This is all I needed to solve this scenario. But before we solve the scenario, let's go ahead and see what the answer is. And if you said C, like you all did, 100% of the answers that I've seen said C, outstanding. Now let's take a look at what a stage 3 uterine prolapse is. Well, first, we have to know what uterine prolapse means, and that means that the uterine has fallen from its original location. And you can have up to 4 stages. The first stage, or the first image, tells you, hey, this is what a normal uterus looks like. It's positioned right above the bladder, nicely in its location. However, when you have stage 1 prolapse, that means it's kind of falling down, and it falls down and it's headed down towards the vaginal opening. And stage 1 is the uterus is in the upper half of the vagina, whereas stage 2, the uterus has descended nearly to the opening of the vagina. Stage 3, the uterus protrudes out of the vagina. And stage 4, that uterus is completely out of the vagina. So our patient is at a stage 3. Now, stage 3 cystocele is a little different. In fact, does anybody know what cystocele is? Go ahead, type in the chat. If you've gone to MedTerm, you may remember. Anybody know what cystocele is? All right, so let's do a brief anatomy or MedTerm. A cyst is a sac filled with water, right? And your bladder is also, well, cyst is a root word for bladder, because your bladder technically is a sac filled with water, right? And that term seal, that suffix seal, means hernia or herniation. So that means your bladder is herniating. And just like uterine prolapse, when your bladder prolapses too, that's called cystocele. So we have three stages. In stage 1, grade 1, the bladder, it's kind of stage 1, the bladder's just coming down just a little. It's coming out of the vaginal opening. Stage 2, that bladder is right at the opening. In stage 3, the bladder is all the way out, right? So our patient had a stage 3 or grade 3 cystocele. And she came to the doctor for the ring pessary, that fitting. And as you can see, this little device here, this bluish color device, is actually keeping the uterus and the bladder intact. So that's a very, very important device. How many of you have anybody ever wondered how someone could have cystocele and um, uterine prolapse? Anybody know how you can get that? And obviously, this is a woman. Yeah, having a very large baby can do that. Yep, it's a result of childbirth. Or I'm not going to say anything else. I'll just keep it quiet. All right. So here, let's go ahead and solve this. Here are our diagnoses. All right. So we have stage 3 cystocele, stage 3 uterine prolapse. Our procedure, the pessary fitting, right? So I'm going to say stage 3 cystocele is the first listed or the primary diagnosis, but I think it could be either or because the treatment is directed at both. But that's not really going to impact our code selection. So let's go ahead and look at the codes, and we'll begin with A, 57150. This is the code for irrigation of the vagina and or application of medicament for treatment of bacterial, parasitic, or fungoid disease. No, we're very clear. This patient's here for a pessary fitting. All right. So 57150 is incorrect. 57155, this is insertion of uterine tandem and or vaginal ovuoids for clinical brachytherapy. No, we're not having brachytherapy. So B is incorrect. But C, fitting and insertion of pessary or other intravaginal support device. Yes, that is correct. Now let's look at 57170. This is a diaphragm or cervical cap fitting with instructions. No. And like that, C is the correct answer. And most of you got it correct. And I just want to say outstanding. All right. We're going to go to our next scenario, and I'm going to ask Miss Carla to come to the fore.
All right, coders, answer A, 57460, R87.619. Answer B, 57452, 57454, R87.619. Answer C, 57455, R87.619. And answer D, 57461, R87.619. Case 2, indications, 21-year-old G3 P1-0-2-1 found to have an abnormal cervical pap smear with possible LGSIL. She presents for follow-up pap smear and colposcopy exam. Pubic hair is shaved. Negative inigual adenopathy. The urethra, the introitus, and anus are grossly normal. Vagina is long, and an extra long Pedersen speculum is needed. Cervix is posterior, uterus anteverted, normal size. Some tenderness of the ignatia to deep palpitation. No cervical motion tenderness. Normal discharge. Pap test was performed. Coloscopic procedure. Speculum was inserted for the coloscopy. An extra long, narrow Pedersen speculum was required and the cervix was visualized. 3% acetic acid was placed and the T-zone is large and bleeds to touch. The 3% solution was placed and the 3% acetic acid was placed and several acetone white lesions were noted, particularly at the 12 and 11 o'clock positions. Lugo solution was placed and there was no uptake at the 6 and 11 o'clock portions of the cervix. 4% topical lidocaine was placed without epinephrine, followed by 1 cc of 1% lidocaine, also without epinephrine. A lead biopsy was taken of the cervix without difficulty, and this also cauterized the bleeding. Instructions given to the patient that she must refrain from intercourse for at least 1 week. She is aware to call if any severe pain, bleeding that does not stop, foul odor, or fever. She is aware the results will take approximately 1 to 2 weeks and she will receive direct notification. What are the CPT and ICD-10 CM codes? All right, coders, let's get it. Let's code. You have 2 minutes. Time starts now.
All righty. Outstanding. A good bit of you, a good number of you got it correct. And I love it. Okay, so we're going to get started with our keywords. Abnormal cervical pap test. I think I'm out of sync here. These aren't correct. Okay, not in the correct order, so I'll just go ahead and highlight all. There you go. All right, so we have an abnormal cervical pap test. I'm not going to highlight this possible LGSIL, that's low grade squamous epithelial lesion. They think it's possible, but it's not confirmed, so I'm not going to highlight it. I am going to highlight PAP and colposcopy and negative inguinal adenopathy, speculum inserted, colposcopy, extra long narrow Peterson speculum, 3% acetic acid placed, several white lesions, Lugol solution placed, 1 cc of 1% lidocaine, a LEAP biopsy was taken of the cervix. And if you said A was the answer, outstanding. So, what is this procedure? Well, this patient had a LEAP biopsy. Well, they had a colposcopy, right? And within that scope, that colposcope, and this is an example of the colposcope. Well, the speculum is in there, and then at the end of it is a scope, and they're just looking around the vagina. And they are going to carry out a loop electrosurgical excision procedure. In other words, they're just going to take some of that tissue. Here's a better image of the loop procedure. So, electrosurgically, they're going to take this loop excision, just scoop it on out. And as you can see, here's your speculum. And within that speculum, they did carry out that PAP. But you can rest assured that the PAP smear is going to be bundled in the colposcope, and the LEAP biopsy needs to be coded. And LEAP is the acronym for Loop Electrosurgical Excision Procedure. So let's go ahead and solve it. The procedures: colposcopy, LEAP biopsy, inventory of the diagnoses, abnormal pap test. There's no confirmatory diagnosis of that squamous cell. So let's select the code that best matches our inventory. So here in the under the endoscopy section, there you go. So this code, I'm going to go ahead and chun my section. So because this is one big old family, I'm going to go ahead and just distinguish them. If you want to put these distinctions outside of the code, you can, but I think it's a little neater, so I'm going to train my eye to look right. And 57454 is the code for biopsy of the cervix and endocervical curettage. 57455 is biopsy of cervix. 56 is endocervical curettage. 460 is your loop or LEAP biopsy. Look what I did. I went ahead and just made the association because loop is also LEAP. They're synonymous. Okay. And then 461 is loop or LEAP conization. And that's it. And on site, we can just see what our surgery is because we know we had a LEAP biopsy, and this is a colposcopic or colposcopy procedure. So A 574, sorry, 57460 is our answer. And if you got that right, outstanding.